Now, does that work?
Yeah, that's good.
Yeah, cool. All right. So, again, thank you for having me today. I'm Jason, and on behalf of the Monash DERMSOC, I'll be going through the dermatology revision lecture. So, just quickly introducing us. So we're a student-run interest society with a common passion in dermatology, and our aim is to bridge the knowledge gaps in the existing dermatology teaching at medical school and create a space for us to connect and network with the dermatologists from across Victoria. We hold two major events throughout the year, mainly the Dermatology Careers Night and the Procedural Skills Workshop. So the following year, if you guys could keep an eye out for those, that'd be great. So let's just get started. There are a lot of conditions to cover for derm. So for the lecture today, I'll just go through the main sort of things to know for each of the conditions, and for the details, if you guys want to come back to the slides at a later time to have a read through if you're interested, I think that'd be great. So to start with a bit of an overview of derm. So to approach studying derm, I think the main parts are knowing your buzzwords and being able to spot diagnose based on the photos. And the best resources out there, as I'm sure you're all aware, is DermNet. They have great summaries of all the derm conditions and got great selection of photos as well. And another resource I would like to recommend is the A to Z of Skin, which is published by the college itself, and it's written up by Australian dermatologists. So we have local information to refer to. If you guys don't have as much time in your hands, then I'd say go look up the conditions on Google Images and have a look at the photos that sort of pop up on the first page. They're the photos that the faculty is most likely going to use for the exam anyway. But just be familiar with how the lesions appear for different conditions and sort of memorize them and be familiar with those. OSCEs, I don't think there will be an OSCE specific station for derm, but there have been ones in the past. So in case you want to prepare, just practice describing the lesions, which we'll go through later on, and some management counseling for common conditions like eczema, psoriasis, or skin cancers. We'll be publishing study resources, summary posts as well on our DERMSOC page, so follow them as well. So history taking for derm using the WWQQAA frame. So starting with where did it start? Did it spread? Did it become generalized? Is it symmetrical or is it just one-sided? How long has it been there? Is it getting worse, getting better? Describing the lesion is very important in derm. And associated symptoms like your itch, pain, bleeding, etc., and aggravating and relieving factors, as always. The skin anatomy. So skin's made up of three big layers: epidermis, dermis, and subcutaneous tissue. So from the top to bottom, epidermis is an avascular layer of skin, and it's made up of keratinized, stratified squamous epithelium. Epidermis is then broken down into five layers again. So stratum corneum, lucidum, granulosum, spinosum, and basale. And the diagram on the right shows those layers of the epidermis. Below the epidermis, you've got dermis, which is a thick layer of connective tissue, and it contains all your blood vessels, nerves, immune cells, sweat glands, hair follicles, smooth muscles, everything like that. And below that, you've got the mainly fatty tissue, which is the subcutaneous tissue or hypodermis, and it may contain some blood vessels and nerves as well. And then we'll commonly be referring to this Fitzpatrick skin types, particularly for skin cancers, but essentially it's a way of subcategorizing different types of levels of pigmentation of the skin. So going from type 1, which always burns, never tans, all the way up to type 6, where people never burn, tans very easily, and they're deeply pigmented. And these we'll come back to in skin cancer when we discuss risk factors. Derm treatment principles. We want to, as with all medical conditions, we want to start with simple things first, so things like lifestyle changes, and for derm topical agents, we can use light therapy if they're applicable. And then if the conditions are severe enough, then we can consider oral medications as well, whether they're non-immunosuppressive or immunosuppressive. And for some conditions, there are biologic agents which target specific immune molecules within the pathways, and they've proven to be quite effective for your inflammatory skin conditions like psoriasis or eczema. So we'll go and talk a bit about how to describe lesions, and here's a nice flow chart for it. So there's a lesion. We can divide them into either if they're flat or raised. If they're flat, then depending on the size, they're either called a macule or a patch. If they're raised, then we can go to whether they're soft and filled with fluid or they're firm and solid. If they're firm and solid, and they present as like a lump on a small local area, then depending on the size, we can divide them into either a papule or nodule. If they sort of present on a larger area with a bit of a raised surface, then we can consider them as plaques or wheals, depending on the presentation. For soft fluid-filled lesions, we can divide them into whether they're fluid or pus-filled. If they've got serous fluid, then depending on the size, we can just divide them into vesicles or bullae mainly. And if they've got pus in it, they can be called pustules or abscess if larger. So just quickly revisiting these common terminologies for lesion descriptions. So macules and patches, both flat, non-palpable lesions, often of altered skin color. And if they're less than 0.5 centimeters, they're called macules, bigger patches. Papules and nodules, raised, hard, palpable, dome-shaped lesions. And if they're less than a centimeter, they're called a papule, greater, a nodule. A plaque is a flat-topped, slightly raised lesion, or they feel like different to the normal skin, and they might have some scaling on top as well, commonly found in conditions like psoriasis. And then you've got the fluid-filled lesions, so the vesicles and the bullae, usually serous or hemoserous in nature. And if they're smaller than 0.5 centimeters, they're called vesicles, larger they're bullae. And if they're filled with purulent material, then they're called pustules. There are other terminologies that people should be aware of, but I'll just be going through them as I mentioned them in the later slides. And then the next few slides, I've just prepared some flow charts and lists of differentials for different dermatological presentations, pigmented lesions, shiny lesions, all those alike. You can have a read through them in your own time, but I think that gives you a good overview of how to think about different conditions based on the presentation of the lesions. So scaly erythematous lesions, shiny translucent lesions, and pigmented lesions. All right, and if you guys have any questions, feel free to chuck them in the chat and we'll try and get back to them sort of at the end of the lecture, depending on the time. All right, so moving on to the benign and malignant skin tumors. So skin cancers are broadly divided into three major types. So your squamous cell carcinomas or SCCs, your basal cell carcinomas or your BCCs, and your melanomas. So starting with the SCC domain, we've got three different stages within that as well, starting with actinic keratoses. So commonly referred to as sunspots or solar keratoses. These are partial dysplasia of the skin cells, the keratinocytes, because of the cumulative exposure to sun and UV. These are not cancers, and they have a pretty low risk to transform malignant, less than 0.1%, but we want to still treat them because they're an indicator for higher cancer risks. Obviously, the more sun damage you've got, the higher the chance you have for various skin cancers. Risk factors, and these are common for pretty much all the skin cancer types, but basically fair skin, so Fitzpatrick type 1 and 2, with history of sunburns, outdoor work and recreation, again relating to the sun exposure, age, and immunosuppression. So these lesions, so the actinic keratoses, present as these scaly lesions, sort of yellow or white in color, with a bit of an erythematous base. And these commonly present on sun-exposed skin, so places like face, nose, ears, chest, scalp, back of hands, most commonly. And as I've mentioned, we want to treat these if there's a lot of them. Obviously, prevention will be very important. So sun protecting, wearing hats, wearing sunscreen properly are all very important lifestyle measures. And for the actual therapy itself, we can either freeze them off, or if they span across a wider area, so areas like on the forehead, we can choose to use what we call a field therapy. So where we use topical immunomodulative agents like your 5-fluorouracil cream, imicamod, or 3% diclofenac gel. And what we aim to do is to provoke an immune response against these dysplastic skin cells and get your body system to clear these away. We can shave them off or curette them off if they're a bit bigger or they present as horns. So the next up is Bowen's disease, which is an SCC in situ, meaning full thickness intradermal carcinoma, but they haven't invaded the basement membrane yet. They have a higher rate of transformation into SCC, about 5%, and they can be a bit tender and uncomfortable on palpation or if we're trying to scrape the crusts off. Risk factors are quite similar with an addition of a few more. And we obviously want to treat these. So again, freeze them off, use topical chemos. We can use a photodynamic therapy where we use light to treat these conditions. And commonly we want to surgically excise them depending on the size. And we want to make sure we get these people to get ongoing skin checks with the GP or the dermatologist, since obviously these are pre-malignant lesions and they can come back or become malignant into SCCs. So the actual SCCs are the ones that have then gone on to invade into the dermis, and it's the most common skin cancer in immunocompromised population, and that's the reason why for higher risk patients like your transplant patients, we want to have them annually skin checked with a GP or a dermatologist. Risk factors are again, by and large, similar: chronic sun exposure, UV exposure, your lifestyle things like smoking, fair skin, age, previous histories, immunosuppression, and things like that. And these will present as raised scaly lumps on sun-exposed sites, and these will be tender. So I think a good distinguishing factor between a less, I guess, a more benign lesion versus a malignant lesion is if you give it a squeeze, the patient will flinch and be like, oh, it hurts quite a bit. They feel firm and they've got crusting, which is, again, a bit more severe than the ones you'll find on AK or bones. And you might find some ulcerations as well and recurrent bleeding. For the malignant lesions, we always want to cut them out pretty much, usually a 5mm margin. And shaving or curating off is not ideal because of the level of invasion you'll find. We can cryo them if they're smaller and they're less malignant, and we can consider chemo and radiotherapy for sort of metastatic lesions. Just quickly touching on keratoacanthomas. So these are considered to be forms of well-differentiated SCCs, and what they present as is they start off as a small papule initially, but then they become rapidly enlarged, and they have this volcano appearance with a keratin plug in the middle. These then sort of self-resolve after 6 to 12 weeks, but when we find them, we'd like to get rid of them surgically. So this is just a summary diagram showing the different stages and progression to the squamous cell carcinoma from AK. So that's the summary for the squamous carcinoma side of things. Next up is the basal cell carcinoma. So these are the cancers that arise from the basal layer. So if we remember, the epidermis has 5 different layers. So these arise from the deeper innermost part of the epidermis in the basal layer. And it's the most common skin cancer. Risk factors, by and large, same as the SCC. And the buzzword phrase that you want to know for the BCCs are your pink pearly nodules or papules with rolled edges and underlying telangiectasia. And this applies for the nodular BCC. We'll find them on sun-exposed areas again. Trunk, quite common, upper lower limbs, earlobes, face, all those places. And they're considered, I guess, a good cancer in a way because they're slow growing and they very rarely metastasize. Management, again, lifestyle measures, sun protect, SNAP-W, addressing those, regular skin checks. And then we can use topical agents if they're more sort of superficial type of BCC, which we'll go through later on. So we use agents like imiquimod or 5-fluorouracil. But for most part, we again like to surgically excise them with a bit of a 5mm margin, or we can shave or curate them off if they're superficial type of BCC. And we can consider this microscopic surgery called Mohs surgery for cosmetically sensitive areas like the face to minimize the amount of tissue that we take off from the skin and allow better healing with less scarring. Chemotherapy we can consider for smaller low-risk tumors, and radiotherapy if they're hard to treat surgically. So these are just different types of BCCs. Nodular type is the most common type, and that's the one you guys should be aware of. Those pearly, shiny nodules with telangiectasia and rolled surfaces, rolled edges, I mean. And these can ulcerate, and hence the reason why they got the name rodent ulcer. You've got the superficial type as well, which present more like a plaque sort of shape. but with similar characteristics. So shiny surface, pearly, rolled edge, bit of rolled edges, and underlying telangiectasia. And when you stretch these lesions, these show really that shiny surface and pearliness that are commonly found in BCC lesions. And the last type is your infiltrating or the morphic type. These present as more like scar-like lesions, indistinct borders, and they're harder to treat because they have indistinct borders. So often we don't get clear margins when we excise them in the first place. And we commonly find these on the midface and the nose. So the last type of skin cancer, which also is the most significant one to know, since they have a very high mortality rate, account for about 70% of skin cancer deaths, is melanoma. So these are malignant transformation of the melanocytes, which usually live in the basal layer of the epidermis. Risk factors, sort of similar. Sun exposure is one of them, but the difference to the BCC and the SCCs is that with those ones, we talk of cumulative sun exposure. So the older you get and the more sunlight you get and the more UV damage you get, the higher the chance of you getting SCCs and BCCs. Whereas for melanomas, it's actually more linked to like your intermittent episodes of acute sort of intense sun exposure. So after a certain period, sort of the risk profile of you getting a melanoma doesn't change that greatly, even depending on the amount of sunlight you get afterwards. So that's a bit of a difference to the other types of skin cancers. But other risk factors like immunosuppression, previous history, fair skin types all apply the same. And obviously, if you've got a lot of freckles and moles to start with, then there's a greater chance that those can transform malignant. Clinical features, so these can pop on anywhere in the body, not just sun-exposed areas. So this does come back to that mention about the different risk factor profile. And these start off as sort of pigmented lesions, which are looking a bit different. And there's a rule to apply, which is the ABCDE rule. I'm sure you guys have heard of this before. But basically, we'll look for domains like asymmetry, irregular borders, variation in color, so different shades of brown, black, or even white or blue shades, diameter greater than 6 millimeters, and they're evolving, so changing in size, shape, color, or if it's a new lesion. And they look a bit funny. And then we've got the extra EFG for your nodular melanomas, which are elevated, firm, and growing. So there's a diagram which compares a benign and a malignant lesion based on the ABCDE approach. And there are 4 different types of melanomas. The most common one to be aware of is the superficial spreading melanoma, which accounts for about 70% of the cancers, melanomas, I mean. Common in the upper back for males and lower limbs for females. And interestingly, only 25 to 30% of these melanomas actually arise from pre-existing moles. So more often than not, these lesions just pop up from a sort of a seemingly normal skin. But these tend to have a better prognosis compared to the next one, which is the nodular melanoma. These are more aggressive since they grow vertically, more vertically first before going radially. So they have a vertical growth phase a lot quicker, and they don't really follow the ABCD rule either. So these ones we really want to keep an eye out and treat them at the first instance when we find them. Lentigo maligna melanoma. So if you call it a lentigo maligna, it's an in situ cancer. If you add melanoma at the end, they're the invasive cancers. And these are better correlating with the chronic exposure to the sun. So these are commonly found on faces of old people. These relatively progress the slowest to malignancy. So they're again considered a better type to have. And then finally, you've got the acrolentiginous melanoma, which are found commonly in Asian people and darker skinned people. And these are found on your palms, soles, nail beds, fingers, and all those sort of places. Just quickly touching on Breslow thickness. So it's a measure to most commonly used to classify these primary melanomas. And it's basically the thickness of these cancers on an histology side. And these are the best prognosticating factors for melanomas. And we later on, when we go back and cut them off, so when we do repeat wide local excision, the margin is decided based on the Breslow thickness as well. I put down Clark level as well, but these are less used, less relevant nowadays because they're not really that useful for prognostication, but I just put it there for your interest's sake. And that's just a diagram showing different Breslow thickness levels. So for investigating melanomas, we want to do total body examination, so thorough look at a person's whole body, and we want to use the dermatoscope to have a closer look if there's any suspicious lesions. And for suspicious lesions, we want to do an excisional biopsy. So it's a close margin cutting off of these lesions. We aim to cut the entire lesion out, usually a 2 mm margin. We can consider what we call an incisional biopsy for lesions that are quite big, or when we don't want to cut out the entire lesion at an initial go. And we can consider sentinel node biopsies if they come back to be greater than 1 mm thickness. We can do other imaging like CT and PET to look for any METs. And to manage these patients, again, sun protection, very important. And then active surveillance for patients who've had melanomas in the past. So every month for 2 years, and then every 6 months for 3 to 5 years. And if they're confirmed to be melanomas on the excisional biopsy, we want to come back to that site and do a wide local excision based on the Breslow thickness. And if the adjuvant lymph nodes come back to be positive, then, the sentinel lymph nodes come back to be positive, then we want to do either clearances and adjuvant therapy like chemotherapy or radiotherapy. There are newer forms of therapy called immunotherapy, where they target specific molecules that are found more commonly within melanomas. So these have proven to be quite useful as well. So that's the different modalities of treatment for melanoma, but by and large, we want to cut them off and we want to regularly survey them afterwards. Quick list of differentials for other pigmented lesions. So the main one are your melanocytic nevus, or what we call moles. These can be congenital or acquired, and there are 3 different phases. So coming from junctional, and then they migrate deeper down to compound and then intradermal. And they initially present as your typical mole, a bit more hyperpigmented lesion at the surface of the skin. And as they migrate down, they become more papular, more raised, and they become more skin colored, and the pigment fades away. So there's different photos at the bottom. And then there's other pigmented lesions like your lentigos, which are these hyperpigmented macules, commonly on sun-exposed areas. Serokeratoses, which are flat raised papules with waxy surfaces, warty, and they sort of show like stuck-on appearances. And then others like atypical nevus, pigmented BCCs, pyogenic granulomas, SCCs, all those kinds of different things can be differentials for a melanoma. So that's all. That's all for the skin cancers. That was quite a lot to go through, so sorry for that, but we'll just push through for now. So moving on to the next part, which is the inflammatory skin conditions. So dermatitis is a terminology. It's a sort of an umbrella terminology to refer inflammation of the skin, commonly affecting the epidermis, and these can be broadly categorized into endogenous or exogenous dermatitises. So starting with atopic eczema, dermatitis, or also known as eczema. It's the most common inflammatory skin disease, present commonly as generalized skin dryness, itchiness, and rash, mostly in kids, but people commonly grow out of them as they age, and it's part of the famous atopic triad of eczema, asthma, and hay fever. Whole bunch of triggers for eczema, but there's a good mnemonic for it, which is scratch. So things like soaps, chemicals, rough, so sand, animals and allergens, terrible infections, clothing, particularly wool or synthetic material, heat, and other triggers like frequent showering, stress, all those ones. So how these present are your poorly demarcated, which is different to your psoriasis, which is well demarcated, warm, dry, erythematous rash with episodic intense itchiness, plus. These patients will have excoriations, so scratch marks, and they might have what we call a lichenification, which is a thickening of the skin because of chronic rubbing. They might have some secondary infections where you might get some crusting and the oozing on the top. And distribution-wise, you'll get them on the flexural surfaces of the elbows and the knees commonly. And on babies, you might find them on the face or the extensor surfaces as well. They're clinically diagnosed, but you can run some other investigations to try look for other aspects of eczema. And for management, lifestyle management of eczema is very important. And there's an ABCD mnemonic for this. So avoiding triggers, so avoiding soaps, irritants, and overheating. Bathing, so bathing is actually fine, but we want to keep them short and use lukewarm waters, not hot water, and no soaps. Clothing-wise, we want loose clothing and materials that are non-irritating, so avoid wool and synthetic fibers. And then it's damage prevention, so using moisturizers quite frequently, especially after baths, and cutting nails to avoid kids from excessively scratching the area. And then finally, education about the condition and the corticosteroid therapy. We can do oatmeal baths if the skin's very itchy. We just put a half cup of oats into a sock or stocking and add them to a bath water. And if someone's having a flare, we can consider what we call a bleach bath as well, where we literally put in a small amount of bleach into a tub of bath water, which we can do daily to try and reduce the bacterial skin load. And then there's also this thing called wet dressings, where we put damp tubular bandages over like the moisturizers and the topical creams to try and increase the penetration of those agents into the skin. So moving on to the sort of pharmacological therapies, I know there's a lot, but the main ones to be aware of are your topical corticosteroids. And there's a lot of, I guess, fear towards using topical steroids within the community, but I think as a GP or as a doctor, I think it's very important to emphasize that, by and large, these agents are quite safe to use if they're used appropriately. And we actually want to use them quite aggressively at the start to really get these lesions to, calm down and until all areas are completely clear, because recurrence is more common when inflammation is undertreated. So really sort of giving a proper education around that, I think it's very important. So for choosing which potency steroid to use, so on the face where the skin is a bit thinner and weaker, we want to use weaker steroids. So agents like hydrocortisone or Advantan ointments. Whereas on the body, we can use stronger steroids. So things like most commonly diprozone or Elifrat ointments are commonly used. Look, the steroids do have side effects, and that's why we want to use appropriate duration and potency. So things like skin thinning, easy bruising, striae, and telangiectasias. These are reversible, though, on cessation of the use. And less than 10% are actually systematically absorbed. So we really don't need to worry about the systemic side effects of steroids unless you use it over a long period of time and you're literally slathering it on all over your body. So that's the topical corticosteroids. And then for face, where we don't want to use them for a long duration, we can use steroid-sparing agents. So calcineurin inhibitors like tacrolimus or pimecrolimus. There can be a bit of stinging at the start, so we just warn patients about that. Antihistamines to help with the itch. And then if the topical therapy doesn't work, then we can move on to systemic therapies. So things like light therapies, short course pred, systemic immunosuppressants like cyclosporin or methotrexate, and then there are newer agents like dupilumab or JAK inhibitors, which are quite good as well. So there's just a simple sort of flow chart of what to do for eczema patients, depending on the severity. And complications, the most significant to be aware of are your secondary infections. So if they're bacterial infections, they're called impetiginization, where you get these most commonly staph aureus. So you get like these golden crusts on top with a bit of oozing. And we want to get rid of these crusts and use antibiotics. So topical if they're sort of localized, so mupirocin 2% or Bactroban ointment. But because the resistance is becoming a bit more prevalent, we want more commonly using oral antibiotics like Fluclox. They could be super infected with HSV as well, in which we call it an eczema hepaticum, and these are sort of considered more serious. So we want to use oral antiviral agents and possibly admit, depending on the condition of the patient. So that's all for eczema. And so moving on to seborrheic dermatitis and cradle cap. So these are inflammatory conditions which are abnormal immune response to Malassezia furfur, which is a yeast species which naturally grow on skin. And the main feature for these are your greasy scales, so yellowish scales with an underlying bit of erythema. Depending on the presentation, age of presentation, we can divide them into cradle cap or just your normal seborrheic dermatitis. So cradle caps are found in infants of first few weeks of life, present as these yellow scales with a bit of underlying erythema, usually found on the scalp as well as on the face and flexures. And about a third of these cases do go away on their own, usually within weeks to months. So not a great concern there. And if they sort of come on during your puberty and onwards, they're considered seborrheic dermatitis, associated with oily skin, and hence the reason why they start sort of at that age around puberty. And they're commonly found as these greasy, flaky scales on areas rich in sebaceous glands. So commonly on the scalp, center of the face, around the ears, forehead, and also the beard area. There can be a bit of itchiness, but not as severe as eczema. And then on the scalp, you'll find some dandruff as well. So you can see the photos there. On the far left side, you've got sebderm on the scalp, so you get a lot of dandruff on there. And then the other two photos showing cradle cap, so greasy scale and a bit of erythema on the body and the scalp. Management-wise, similar to eczema, use topical steroids. Start with lifestyle changes, avoid triggers, use topical steroids to settle down the acute inflammation. And then because these are caused by fungal agents, so yeast, we can use antifungal agents. So things like ketoconazole, selenium sulfide, or zinc pyrithione. To help with the scaling, we can use keratolytics to try and get rid of the scales as necessary. And then that's pretty much it. A summary table comparing eczema to sebderm. You can have a read in your own time. And then there's contact dermatitis, which are dermatitises caused by external agents. So most often, chemicals and the like. Just to note the difference between an irritant and an allergic contact dermatitis. So an irritant contact dermatitis is a non-immune toxic injury to the skin barrier caused by different agents. So things like repeat exposure to water, soaps, cleansers, acids, alkali, all those kinds of things can cause irritant contact dermatitis, usually common in cleaners, hairdressers, and food handlers. Whereas an allergic contact dermatitis is obviously an allergic reaction. So it's a type 4 hypersensitivity reaction to the allergen exposure. And then you go through this whole process of being sensitized. And then the next time you have contact with these agents, you get the repeated rash, often worsening in severity. So for the irritant contact dermatitis, so for both, we want to avoid contact with the agents, but for irritant contact dermatitis, because it's a simple physical injury, you don't need to change jobs. You can just be careful with what you do with handling the materials. Whereas for allergic contact dermatitis, because these people have now been sensitized to the agents, they will need to consider changing jobs, as contact to these chemicals will always cause reaction. But they do present sort of similarly with your erythema, a bit of scaling, oozing, typical picture for a dermatitis. Here's just a summary table for different types of other minor types of dermatitis. So moving on, your other main inflammatory condition, which is psoriasis. So these are sort of classic, well-demarcated, inflamed, salmon pink, scaly, silvery plaques. So that's the buzzword that you should know for this condition. Usually found more commonly in Caucasian population, and the risk factors associated are things like your alcohol, smoking, obesity. So SNAP-W is very important. And then stress, trauma, medications. And for this particular subtype called a guttate psoriasis, it's associated with a strep GAS infection. So again, the chronic plaque psoriasis subtype, which is the most common, you'll find these thick salmon pink scales with overlying scale, which are well demarcated. They're found commonly on extensive surfaces of the elbows and the knees, as well as on the scalp, umbilical area, and you might get some nail psoriasis as well, where you get dystrophy, ridging, onycholysis, pitting, and subungual keratosis. So these sort of nail changes. You also get psoriatic arthritis, which is more your rheum condition. And the itchiness is not as severe as eczema. It's a bit milder in nature. And then there are other phenomena that are associated with psoriasis, like a Koebner phenomenon or Auspitz sign. Different types of other subtypes of psoriasis. The one to be aware of more is your guttate psoriasis, which present as these acute eruption of quite small but well demarcated scaly lesions across the whole body, and these follow after a group A strep infection, like a strep pharyngitis. These do self-resolve after 2 to 3 months, but there are a certain population who then progress to developing chronic plaque psoriasis later down the track. And then there's other types of psoriasis, I guess, to be aware of. Pustular and erythrodermic psoriasis. These are generalized eruptions. Patients can be quite sick and they need hospital admission, but yeah. So to manage psoriasis, similar approaches, lifestyle management, avoid triggers, moisturize well, SNAP W, and sun exposure actually helps with psoriasis since exposure to a mild, gentle amount of UV can actually help treat psoriasis. So gentle sun exposure is recommended. Topical agents, so we want to use steroids and also vitamin D analog, so vitamin D basically, which helps to settle down the excessive proliferation of the keratinocytes, which cause that thickening of the scale. And these sort of come often in combination with the topical steroids. We can use coal tar solutions, dithronol creams, keratolytic agents like salicylic acid to try and get rid of that excessive scaling on the top. And then for your more generalized therapy, so you can use a UV therapy, so a narrowband UVB therapy, which helps settling down that inflammation of the skin. And then systemic agents like your methotrexate cyclosporin, acitretin, and premolast, all those things. And then the biologic agents have been proven to be quite good for treating psoriasis, so targeting specific molecules like TNF alphas or interleukins, different types. Urticaria is your next stop, which are characterized by these transient erythematous, blanching, edematous, or pruritic lesions, which are called wheals, that develop quite rapidly and then go away within the next 24 hours. Often associated with angioedema as well, which is swelling that you find. And about 50% of the causes are actually unknown. So we don't know why these are caused. And if they last for more than 6 weeks, then we classify them as chronic spontaneous urticaria. And then the other infections that can be possible are things like infections, drug, food allergies, insect bites, vaccinations, certain substances when you contact them, so contact urticaria. And then even physical factors like heat, sunlight, water, pressure, but all those kinds of things can cause urticaria as well. So the hallmark feature for urticaria are these wheals, which are transient, migrating, itchy rash, quite itch, pus, that you can see on the photos on the right. And they last for a few minutes up to 24 hours. If they last longer than 24 hours, then you'll be considering other differentials like urticarial vasculitis, for example. You'll find dermographism, which is where you scratch the normal skin and then they become sort of erythematous and raised, similar to what you'll see on a wheal. And you commonly find angioedema as well, so the swelling of the face. And if they affect the laryngeal laryngeal path, then it can cause respiratory stridora as well. So it can be potentially serious. To manage urticaria, again, avoid triggers. That's the main thing for lifestyle. And then we want to use antihistamines to settle these lesions down. And we can take up to 4 tablets of your over-the-counter antihistamines per day safely. But if these don't work, then we can move on to systemic agents and can consider oral pred if they're quite severe, but only for a short duration of time. So I've just attached a flowchart diagram for management of urticaria, depending on the severity. All right, I'm aware that there's not a lot of time, so I'll try and push through the main conditions a bit quicker. So next up, acne caused by obstruction and inflammation of your pilosebaceous unit, which produce sebum, common in sebum-rich areas, as I'm sure we all are well aware of, so face, neck, shoulders, upper chest, and back. Starts around puberty when you get increased production of the sebum, and more common in males, but they do fade away as people age. So we can broadly classify them into mild, moderate, and severe, depending on the presentation. So mild acne are your comedonal acne. So these are non-inflammatory lesions, and we can classify them into either closed or open, which we call blackheads or whiteheads. If they become a bit more inflamed and a bit more pustular in nature, then we call them papulopustular acne, can cause mild scarring. And if you have a severe inflammation and present as nodules or cysts, that's what we call nodular cystic acne. You get a lot of scarring with these, and we really want to treat these appropriately. Severe acne can also be moderate acne that hasn't responded to treatment within 6 months, or any form of acne that's causing serious psychological impact. So if the patient's distressed, then obviously even if it looks relatively mild, we still want to treat them quite aggressively. So just a photo comparing blackheads and whiteheads. And for non-pharmacological management, we want to limit the aggravating factors of acne. So limit medications, avoid hot, humid, and overly sunny environments, which are all triggers for acne, avoid hot spas, Only wash face 1 to 2 times to keep them from excessively drying, because that can actually provoke more sebum production down the track. Use keratolytic agents like salicylic acid to try away the blockage at the openings of the sebum, openings of pilosebaceous units. And don't squeeze acne, because that can drive inflammation deeper down and cause worsening of the scarring. Use non-comedogenic products. Avoid oily makeups, and make sure you wash them off thoroughly after use. And then for the pharmacological management of acne, depending on the severity, again, starting from mild, we can start with topical therapy. So things like retinoid creams to reduce the production of sebum on the skin, and benzoyl peroxidase. So combining those two, you'll commonly find this product called Epiduo. For mild papulopustular acne, we can consider adding on top topical antibiotics like clindamycin or erythromycin. For moderate acne, on top of the topical therapy, we want to use anti-inflammatory oral antibiotics. So these are your doxycyclines, minocyclines, erythromycin. So we don't really use them for the purposes of antibiotic properties, but because these have anti-inflammatory properties as well, that's why we use them. Or in females, where we consider excessive androgen production, that we can consider oral anti-androgen therapy. So things like OCP, so cyproterone acetate, or spironolactone, but not in males. These are not applicable in males. And for severe acne, we want to use this agent called isotretinoin, or trade name Roaccutane, for 12 to 18 months. And these have to be prescribed by the dermatologist. And these need regular blood tests for to check for other side effects. Quite a bunch of them, but the I want to be most aware of are that it's a teratogenic agent. So females need to be on a thorough contraceptive plan, oral contraceptive at least a month prior, and a negative pregnancy test. All right, so that's all for acne. And then next up, rosacea. So these present as flushing and commonly present as flushing and telangiectasias on the mid-face of an older, sort of fair-skinned Celtic English origin ladies, most commonly. A lot of triggers, a lot of lifestyle triggers, hot foods, spicy foods, alcohol, hot temperature, stress, anger, embarrassment, all those kinds of things can cause rosacea. And these present typically as frequent blushing and flushing on the central face, as well as a bit of telangiectasia to start with. Can also present on cheeks, nose, and chin. So we call that ace of clubs distribution. And progressing down, we might find some papules and pustules without comedones. So that's different to the acne. And people might have some increased sensitivity. So burning, quite common burning, stinging, or itching sensation. And more commonly in males, you also get this presentation called a rhinophyma, where you get this red, bumpy, and bullous nose, typically described as thickening orange peel skin over the affected regions, quite commonly on the nose. And there can be some eye complications associated as well. Treating rosacea, avoid triggers, most important, SNAP-W, and then we can laser the redness or the bulginess of the nose with different types of lasers. And there's some topical antibiotic agents we can use to try and settle down the inflammation. Just quickly touching on perioral dermatitis, it's considered to be a corticosteroid-induced type of rosacea. What you find is this patchy erythema with these small papules and vesicles erupting around the mouth. Obviously, the triggers are steroids, so stop using steroids, and we can use some topical metronidazole or erythromycin to settle down the inflammation. So that's all for the acne and rosacea type presentations. Ulcers, these are sort of repeated from last year's revision lecture, so I won't go through them now, but you can have a read through them in your own time. It is still an important presentation to remember, though, so I do recommend you guys get your head around different types of ulcers and things like that. Infections, there's a whole bunch of them, but I'll just go through the ones that are more important in the GP setting. So starting with bacterial, impetigo, these are highly contagious superficial bacterial skin infection, also known as school sores, typically seen in children that's going to childcare, and it's commonly caused by Staph aureus. And how they present are these lesions with golden yellow honey crust appearance with a bit of surrounding erythema. These are quite itchy, and the patient and kids will like to scratch on them, but that's no good. So you want to keep them away from doing that. And these can become pustular and bullous as well, in which case they have different subtypes for different presentations. So lifestyle management, we want to keep them away from school until 24 hours from starting the treatment. We want to get rid of these crusts appropriately with warm compresses or bleach baths, and we want to use antibiotics. So topical antibiotics, like again, Bactriban ointments if the site is small, but if they present over an extensive area, then we want to use systemic antibiotics like Fluclox or Cefalexin. Next up is erysipelas and cellulitis. So erysipelas is a more superficial bacterial infection of the upper dermis and lymphatics only, present more as your sharp raised border type presentation and quite bright red in color as well. Which is different to your cellulitis, which is an infection of a deeper layer of the skin, of the dermis and the subcutaneous tissue. And these present more as like poorly defined erythema, a lesser degree of erythema and no blanching on pressure. And there's quite a lot of pain associated and a bit of systemic symptoms as well. And very important to know, like 95% or 99% of the time, there's no such thing as bilateral cellulitis, please. Like I see bilateral cellulitis used way too much on the ward setting, but look, cellulitis is most often unilateral. I've seen like one case out of all the cases I've seen for cellulitis. So please avoid from using bilateral cellulitis terminology. With cellulitis or erysipelas, we use antibiotics to treat them. Because they're most commonly caused by strep pyogenes, we want to use sort of your penicillins, can start orally and then go up to IV if the presentation is quite severe. And then your general measures like analgesics, antipyretics, and elevating legs. And for cellulitis, we want to mark the edges of the swelling as well to progress the settling, to check the progress and the settling down of the erythema. So these are just the two photos comparing. So on the left side, you've got cellulitis, so they're more poorly demarcated, less degree of erythema, whereas you see on the erysipelas side, quite well demarcated and a very vibrant red color that's appearing. Furuncles, basically boils, use topical antibiotics to treat them. Moving on to viral infections. So warts caused by HPVs, human papillomavirus. So we're talking more broadly of general warts you find on the skin. Super many different subtypes, and the different subtypes you find are common warts, flat warts, plantar warts, and mucosal warts. So common warts are typically described as these cauliflower-like lesions that are quite hard, rough on the surface, basically your typical warts. Flat warts present more like a flatter lesion, typically on the face more commonly, and there's a lot more of them quite often as well, since they spread quite easily. Plantar warts are warts that are found on the soles of the feet, quite painful on pressure, and the mucosal warts are your warts that are found on the mucosal surfaces. So most commonly, the ones you'll be aware of are your genital warts. So just photos of different types of warts, so common warts, flat warts, plantar warts, and on the bottom, you've got the genital warts, which is a form of a mucosal wart. So in terms of management, mostly they mostly go away by themselves. So the management is really around like if the patient's sort of bothered by the appearance or if it's causing any sort of symptoms like pain. So if we do decide to treat, it is important that we persist with the treatment once we start it. So different approaches, you can put a duct tape on it and they can go away, which is quite easy. You can use topical destructive therapies like salicylic acid, cryotherapy. They're quite common and effective, but they do cause quite a bit of pain. So you warn the patients before that. And other forms of therapy for warts are less commonly used. Just to mention as well, with the genital warts, 90% of them are caused by the subtypes 6 and 11, but there are subtypes, other subtypes which you want to keep an eye out for, since they can cause your cervical cancers. All right, molluscum contagiosum, also known as water warts, caused by poxvirus, and these present as your typical small, round, dome-shaped, umbilicated lesions. Just basically memorize how they look on the photos. Treatment's not essential. They do go away on their own, but if we want to treat them, we can just freeze them or just scrape them off, basically. Pityriasis rosea, I don't know why GP like always asks this condition. It's not as common, but nevertheless, we should go through it. So it's a acute inflammatory eruption, which is characterized by a herald patch, which is a single solitary patch that initially appears on a back or a chest, then followed by a generalized eruption of these oval-shaped salmon pink papules and plaques with quite thin scales on the border. That's sort of generalized across the body. That's your classic presentation of pityriasis rosea. It's thought to be caused by some sort of a viral infection, but no one really knows what it is. Nevertheless, they resolve by itself without specific treatment and doesn't really have any leftover scarring as well. So there's a photo of the herald patch, which appeared initially, just a single lesion, and then they become generalized eruptions afterwards. Quite important to know this one. I think I've seen it pop up a fair few times on previous questions. I'll just skip over these ones because I'm sure you guys are more familiar with these from the previous years, but there's HSV infection to be aware of, VZV, so chickenpox, starting from macule, erythematous macules to vesicles and then crusted. And most people are vaccinated nowadays. So if someone comes in with a chickenpox, then we want to notify them since they're most likely not immunized. Shingles, basically re-eruption of chickenpox if they've had it in the past, your classic dermatomal pattern, blistering rash, and we want to control the pain quite well with this, since the complication for shingles is your post-hepatic neuralgia, and these can be quite difficult to manage. So getting onto the pain analgesics early on using appropriate medications is important for these. Fungal infection, the one to be aware of in the GP setting is pityriasis versicolor. So these present as generalized macules and sometimes papules, like sometimes scaly papules, which are round with either hypopigmentation or hyperpigmentation. And they're commonly found in areas with high sebum production, since they're, again, related to your Malassezia furfur type yeast. And we want to treat these, since these do self-resolve, we aim to reduce the number of yeast again. So similar agents to Sebderm, we use topical antifungals like your Selsun Gold or selenium sulfide agent. But look, by and large, these are asymptomatic. These are not itchy, doesn't cause a whole lot of problems. So the treatment's really just focusing on symptom management if the patient's bothered by it. Tinea was another form of fungal infection. This did come up in the exam last year, the ringworm type, but basically it's a fungal infection of the hair, skin, and nails. Different names depending on where it happens, and it's caused by a dermatophyte fungus. The clinical feature to be aware of for tinea most commonly is your ringworm type, which is an annular eruption with irregular edge, erythematous edge with a bit of scaling, and there's central clearing. So the center is all fine, and then you see this ring of erythema and a bit of scaling, and hence the reason why they got the name ringworm. And then to treat these, we can use either topical antifungals, so terbinafine agent for localized tinea, or oral agents if they're widespread, or the tinea is on the nails where it's more difficult to treat. So here's just a summary of the different subtypes. I think the ones to be aware of are tinea corporis, which is the ones you find on the skin of the body, also known as ringworms, and tinea pedis, since this one's the most common form found on feet in most areas, also known as athlete's foot. So have a look through this slide and just be familiar with the photos. Hair and nail disorders, I put it in there just for the completion's sake with the matrix, but I don't think these are as common, so you can have a read through. Essentially, androgenic alopecia is your balding because of the hormonal changes in the body. Alopecia areata, which is more autoimmune type condition where you get areas of hair loss. And then I've put in some tables just going through definitions of different types of presentations you'll see with nail conditions. So sorry that the last part is quite rushed. But if you do have any questions, I'm happy to stay back and answer them as we go through. I'll just do one quick question and then we'll probably wrap it up there. So yeah, this one, if you just want to pop the answers into the chat. Yep, so I'm getting a lot of M's, which is correct. It's pityriasis versicolor, 23-year-old guy, probably quite sweaty, and yeah, not causing any troubles, but doesn't like appearance. And just one more question. I might do this one. Sorry. Yep. Yep, so I'm getting a lot of these, which is good. So it's a classic presentation of a pityriasis rosea. I just put down a whole bunch of different conditions that start with the word pityriasis, but that's good. So that's all I've prepared for today. If you have any questions, please feel free to send them through the chat, and I'm happy to stay behind a bit and answer those as well. But yeah, thank you very much.
Cool. Thanks, Jason. That's very useful. Spoken like a true future Derm. It's going to answer some questions out loud that I got. So what's the difference between superficial spreading melanoma and lentigo malignant melanoma? So my understanding is that the main difference is sort of the location in which they appear. So lentigo maligna is more commonly on the face, whereas superficial spreading is pretty much everywhere else, like the arms, back, and legs. They do look very similar though, so yeah, I think the location is the main differentiator there.
Yeah, and I think also like the sun exposure things as well. There's a better correlation. I think it's just a clinical sort of distinguisher between the two. Yeah.
Yeah. And the other question was how to differentiate between pityriasis versicolor and vitiligo. I'm not too sure on this one. I think there might be difference in the location as well. Do you have any thoughts, Jason?
So vitiligo is an autoimmune condition, and they can both present as those hypopigmented macules and patches, but pityriasis versicolor, it's a hypopigmented condition. So you get fading of the pigment, but it's not complete. Whereas in vitiligo, the pigmenting cells are actually completely dead because of the autoimmune reaction. So you'll get really pale, very sharply demarcated I guess apigmentation, commonly on like the ends of the hands or things like that. So when you have a look at the two conditions, the clinical presentation are quite different.
Oh, and then just another question. Do we need to know the specific excision margins for different types of cancer and different sizes of cancer?
Nope.
Yeah, I don't think we got tested in that at all.